morning and welcome to the joint SCA and CTSNet webinar. Good afternoon and good evening to our international colleagues in attendance as well. Dr. Joe Chikwi and I, along with our co-organizers, Dr. Alex Mitnacht and Dr. Matthew Patterell, are excited to welcome you today to this webinar on cardiac surgery in the time of COVID-19. This is the very first collaborative webinar hosted between the Society of Cardiothoracic Anesthesiologists and the Cardiothoracic Surgery Network. At this extraordinary time, the combined support of these societies has been really critical for the development of this webinar. It is clear during this time that coming together, whether at work or at home, is an essential part of human existence, and we look forward to ongoing collaborations in the future. Of note, we've had over 2,500 registrants representing 101 countries sign in for this webinar. We have gathered a panel of experts to speak on topics of importance to cardiothoracic teams, representing a view looking forward to the weeks, months, and years ahead of us. An hour is not nearly enough time, but we acknowledge not only constraints on our panelists' time, but also the challenges everyone in attendance is facing with this pandemic. Thank you especially to our panelists, Dr. David Rich, Dr. Elaine Combs, Dr. Amy Fiedler, and Dr. Sasha Shilcutt for giving up their time today. Without further ado, it gives me great pleasure to introduce Dr. David Rich, the Horace W. Goldsmith Professor of Anesthesiology, President and Chief Operating Officer of Mount Sinai Hospital, New York. Dr. Rich.
Good morning, everyone. I'm going to switch to showing a screen for a moment, and we will get right away into the presentation. So what I will do now is go in this direction here, and I hope that everyone gets a chance to see the screen. Mount Sinai Health System had a dramatic response to the COVID crisis, being in the epicenter of the world, unfortunately, for the last several weeks. And since we have 8 hospitals located in New York City and Long Island, 4.1 annual visits, and you get the idea. We were quite busy in the last several weeks. And so I just want to present a summary of what I presented for the CDC about 10 days ago, which was an overview of the concepts of actually how cardiac surgeons and cardiac anesthesiologists need to be prepared on the upslope, and then I'll get at the end towards the downslope. So basically personal protective equipment, workforce management, physical plan and increasing capacity, and also testing and therapy. And I'll just whip through this very quickly so we have plenty of time for the other speakers. This particular slide has a bit of a downslope here. I'm going to not going to try and flip between different slides here, but essentially we are now, as of 2 weeks later, sitting around 1,000 patients. So the downslope is happening at about half the rate of decline as the upslope during this particular phase. And I'm not sure if that can be true everywhere, but something to keep in mind, because getting back to a state where we're able to do cardiac surgery requires that we be in a different place with critical care. We still have 21 patients that are doubled up in ICU rooms in Mount Sinai Hospital itself. And this is happening just now with 2 critical care units coming back to somewhat normal operations and trying to move people from recovery rooms where we had a medical ICU, surgical ICU, and transplant ICU in exile. So just to give you an idea. This is a timeline to give people an idea about how things have been accomplished. And if I can focus everyone on February 29th, 2020, the first case identified in New York City. Yes, that was at Mount Sinai Hospital. Wasn't that fun? Luckily, that case was managed at home, but we ended up throughout the March effectively getting prepared. And we were also blessed because we were able to do antibody testing, because our research lab was able to bring that into the clinical laboratory under the authority of our state laboratory as of March 24th. We also opened tents in Central Park to accommodate another 68 patients as needed. And by April 4th, we had greater than 1,500 patients. And peak week was pretty much around the middle of April. Moving quickly, I think it's very important that everyone understand that the personal protective equipment hysteria seems to be particularly potent among cardiac surgeons and cardiac anesthesiologists. I'm not entirely sure why. There are plenty of aerosolizing procedures out there, But I think that it's very important for all of us to understand that managing the expectations of our staff and understanding when special droplet and special airborne precautions are necessary is critically important for the well-being of the team. And this is something that will have to be managed locally. And as I've said, for whatever reason, cardiac surgeons and cardiac anesthesiologists seem to be able to be a bit more dramatic than the average physician. I'm not sure exactly why, but we can think about that another time. So also in terms of PPE, there is no way in this nation that we're going to find enough PPE for everyone to use a different N95 for every patient as they walk from room to room. So creating and understanding that also in the ORs, as well as on the floors where we're taking care of these patients, extended use PPE is critical, that we establish these patterns, that we understand what our staff need, and that we do over communication, because the anxiety around PPE is probably the biggest crisis that we have in this, even more so in some cases than patient care. In terms of workforce management, yes, we all have to round, and these are elbow bump rounds that I do. I do them mostly in a white coat. I'm not sure why this particular picture showed me in a suit that day, but the idea is that you must over communicate during this entire process, and this includes getting the ORs ready to go again, daily briefings with senior leadership, twice daily huddles with local leadership, crisis communication, broadcast messages, twice daily calls with our union leaders that were very important in keeping things calm, weekly virtual town halls by Zoom, and something such as an elbow bump round so that leadership is available and seen on the floors. The crisis of well-being should not be underestimated, and not just PPE, some of which is, frankly, plain hysteria, not based upon real data, but the true toll of seeing people dying in very large numbers and seeing patients doing poorly in critical care is something that affects our staff. And having redeployed many of our cardiac surgical and cardiac anesthesia attendings and house staff and the people that we work with, the nurses, the technicians that became a proning team, all of this happened. But it's not going to be so easy necessarily on the way back, because some of this really results in sort of a PTSD state that we're going to have to manage with. So we redeployed, we worked on a team-based care model, which is a way of saying we didn't have enough nurses to go around, so our house staff and our attendings helped fill in. We used volunteers and external staff. Crisis pay negotiations were extremely important with the unions and for the staff. I'm sorry to say, not for physicians and surgeons. We're talking about the people who earn a lot less than we do. Sorry about everyone's stock portfolio this year. Employee engagement, so important. We were very blessed to have food donations, sleeping arrangements from local hotels, respite stations, put all about, very important, and of course the wellness initiatives and crisis hotlines. In terms of physical plan, this is one of our hospital buildings, and these little white inserts that you see in the windows with the little black hole, those are HEPA fans which exhaust air from the room, converting a regular room, whether it be critical care or med-surg, into a negative pressure room. This was important not only for people who have true aerosolizing procedures, but also for the well-being and, again, mental health of our staff, who felt much safer in the hallways when the unit was strongly negative, and this was a very important thing for us to do. Non-traditional care spaces, these little white dots that you see here on this aerial view of Central Park, these are tents built by Samaritan's Purse. This is another one of our hospitals where beds were built in a tent. These tents in Central Park were used. We have, as of today, still about 40 patients under the care of the team from Samaritan's Purse that is managing these patients. And we don't have that capacity elsewhere in our health system. So being creative and using that sort of technique was very helpful to us in caring for patients. Testing and therapeutics, I just want to mention that commercially available lab tests for viral testing are fairly well developed, and hopefully our labs will have that capacity. It's extremely important for your teams. We don't normally pay so much attention to the lab as cardiac surgeons and anesthesiologists. It's time we started paying attention, because the turnaround time, the testing for urgent cases, or if you're in a state where you're allowed to do elective cases, We have to help people understand and have a rational approach to testing. But we also have to get away from this psychotic theory that there are COVID-free zones in the United States. COVID is endemic in the United States right now, and to imagine that we're going to have COVID-free staff, COVID-free zones, badges of people who are COVID-free, and we're going to test them and keep the unclean people away is just unrealistic. We have to understand that masking and social distancing is here for some period of time, even in our workplace of cardiac surgery and cardiac anesthesia. So I want to just be clear on that particular point. Antibody testing is something that we were able to ramp up faster than some other places. And the reason that we were able to do that was because of, we're lucky to have an amazing research laboratory, and we did achieve FDA emergency use authorization for qualitative testing, even though frankly we're able to do titers. And we've used that in general to drive patients to our partner, the New York Blood Center, so that we could stand up and quickly begin a convalescent plasma program. As cardiac surgeons and cardiac anesthesiologists, we get it. We know what plasma is, we know what it does, and I believe that we should be key leaders in assuring that the convalescent plasma program is intact at your institution. Remember, there is now a national emergency access program that's run by Mayo Clinic. I believe that Mike Joyner, who runs it, is actually an anesthesiologist, but independent of his specialty, he's done an amazing job. Next, I want to point out trials. I think it's very important that we, again, as an academic group, because we are an academic specialty, work very hard in establishing the algorithms within our institution so that it is not chaos. We can take control of this even during a crisis phase by coming up with specific patterns of clinical care and really trying to work in such a fashion so that people are not experimenting on our patients. The convalescent plasma donation program, again, you in your local area, I think, have to be, again, facilitators, because the patients will not go to donate plasma unless we as institutions take our recovering patients, whether they be outpatients or inpatients, and encourage them 21 to 28 days after recovery to donate their plasma, hopefully also with valid and reliable antibody testing to guide that. I'm going to skip over this just in the interest of time. Increasing ventilator capacity and innovation. It's remarkable what an anesthesia simulation lab can do, and we were able to take some transport ventilators and specialty ventilators and soup them up to be ready for a surge and requirement for ventilation that never actually happened. But once again, as cardiac surgeons and anesthesiologists, we have this capacity. I think it's extremely important for us to be prepared and understand that if you're in an institution that will not receive enough normal ventilators, that you can actually take home ventilators and upgrade them to critical care capacity. And anyone who needs that information, I can forward the protocol for doing that. The respiratory device usage is obviously massive. In terms of the anticoagulation algorithm, again, we as cardiac surgeons and anesthesiologists understand coagulation better than almost anyone. And it is clear throughout our nation that multiple institutions have now set up protocols for coagulation management. There is clearly some endothelial injury. There is clearly some microvascular thrombosis. There are clearly also VTE and large vessel occlusions in the brain that are occurring. Perhaps it's related to some thrombophilia, or perhaps it's just the nature of this disease. So most institutions are coming up with some sort of anticoagulation algorithm. I encourage you to do so. Again, we're the experts in this. We're past the plateau week. We now have over 3,500 discharged. Again, important to have everyone feel good about things. And then it's about thanking people. It's about showing our gratitude. And remember that it's nice to thank the doctors, and it's nice to thank the nurses, but there are so many other people that give up themselves in this. So whether it's a transporter, whether it's a surgical tech who gets redeployed to do proning, we have to thank absolutely everyone. So I want to thank you for your time. If anyone needs to see a copy of the slides or wishes to see the anticoagulation or other protocols, I will have my team forward them to you. Thank you for your attention.
David, that was absolutely tremendous, and thank you so much for giving us your time and your insights. I want to ask you two questions, if I may. You're speaking to about 1,200 cardiac surgeons and cardiac anesthesiologists around the country. And a particularly important topic for us now is how we restart the cardiac service line. And I know you have a very granular understanding of that. So how are you determining, what benchmarks, what data are you using to guide the timing, and how are you reopening cardiac services at your institution?
It's the best question you can ask, Joe, because we're in the thick of those discussions right now. At the peak, and maybe other institutions will not have that, we had to take every adult ICU bed, 102 of them, and care for about 160 patients at the peak, even expanding into a pop-up ICU where we used anesthesia machines. I believe the peak was 168 COVID patients on ventilators. We're now down to about 120. And we're taking back the ICUs. The key is to take back your ICUs and to staff them appropriately. The biggest concern that I share with the chair of cardiac surgery, David Adams, is that we don't rush into doing elective cardiac surgery, or in this case, urgent cases, since our state doesn't allow elective just now, and that we do not rush into it before we have normal nursing care ratios in our critical care units and the right staff in our OR. So the key issue is it has to be back to enough of a semblance of normal that we can assure that we're doing quality work.
You touched on how you were going to gently roll back into cardiac surgery elective cases. About 120 health systems across the country, in view of the massive disconnect now between revenue and fixed operating costs, are implementing salary cuts across the board for physicians and clinicians. How do you see that, let's say, being managed within your immediate healthcare landscape?
Well, I think that the fair thing to say is that with the likelihood of a global economic crisis that will obviously also affect the healthcare systems, it's very important for our institutions in the US specifically to make sure that you provide all the data possible so you get as much of support from federal allocations as possible so that we can preserve our economics. And part of that is, of course, is keeping our staff paid as well as we can. This is going to be a very challenging year. But I think that considering the margin that most institutions have on the cardiac surgical service line, I believe they will prioritize and try to preserve this. But if anyone thinks that they're going to be as wealthy on paper as they were at the end of 2019 in the middle of 2020, I think that's another thing that they need to awaken to. But it's just a matter of accommodating right now to the economic shock and hopefully preserving our cardiac service lines as best we can. I'm sorry it wasn't the best answer there, but we have no plans here to specifically hurt anyone. But in many institutions where there are RVU-based metrics for compensation, I could certainly see this not being a great year for everyone. But you know, cardiac surgery will come back, and we just have to get through this bump.
Thank you so much for a really, really thoughtful approach and for those insights. We really appreciate your time. I am now going to introduce our next speaker, who's Dr. Alain Coombs. He's a professor of intensive care and director of the intensive care unit at the Paris Pitié Institution. And as such, he has the largest single institution experience in the management of ECMO, specifically for rescue of COVID patients. Good morning, Dr. Coombs.
Good morning.
Good morning. Thank you for joining us.
Thank you, and thank you so much for the invitation. Can you see my screen?
We can see your screen beautifully.
Okay, first, this is my disclosure slide, and I've been working with some ECMO companies, especially for the EOLIA trial, which was a study of VV-ECMO for ARDS. What is the update about ECMO and specifically veno-venous ECMO? Because up to 95, maybe 98% of those patients with severe COVID actually got ECMO for respiratory failure, and very few got ECMO for cardiac reasons. We got some data weeks ago now from China, like the one published in this paper, with very few cases reported about the use of ECMO. In that series was only 6 patients, and actually the results were quite poor. With out of the 6 patients treated, only one was a survivor. And in that small review article summarizing most of the early experience in China, the mortality was very high, actually 94% in that report. It was a little bit better in a later case series, which was published 3 weeks ago now. It was only 12 patients here, and the mortality was around 50%. Still, there was some patients still ongoing on ECMO at the time this series was published, and this is the latest from the US, also very early experience, 32 patients, but it's virtually impossible to derive reasonable outcome data from these patients, because we all know that it takes time for patients on ECMO to recover, and we will need time to evaluate the results of this strategy and this technology in COVID patients. There's also been some papers published like this one about the potential for ECMO being also deleterious in COVID-19 patients, because in that paper, the author was hypothesizing that ECMO might also be associated with a decrease in the lymphocyte count, and also that there may be an increase IL-6 production and concentration in COVID-19 patients, especially those on ECMO, which might also be associated with a worse outcome. So this was the big question initially, though we never have observed this kind of phenomenon in our ECMO patients. And usually for patients, for example, with H1N1, it's very easy to rapidly stabilize the patient while on ECMO. So now a few words about our experience here in Paris. First of all, about the indications, and this is a Lancet Respiratory Medicine paper we published with the International ECMONet group, and with the group which is led by Dan Brody from Columbia in New York City. And we just stuck with the EOLIA entry criteria to decide for ECMO in these patients. It was mostly hypoxemia, which was the main reason for entry and for deciding the ECMO initiation. And it was mainly the PF ratio below 80 for more than 6 hours, which was the most frequently indication for ECMO over the last few weeks. We also organized the activity at the regional level here around the in the Greater Paris area. The Greater Paris is a 12 million people area, and we organized the activity with all centers, especially ICUs and cardiac surgery centers all around this big area. And these are here our initial contraindication. Age obviously was a contraindication. We defined an age over 65 to 70, which was the upper limit. And actually very few patients got VV ECMO beyond that age. Massive obesity also was a contraindication, although more relative than absolute. Severe comorbidities, COPD, cardiac failure, thyrosis, chronic respiratory insufficiencies were also a contraindication. Also, the common other contraindication, patients with hematological cancer, advanced metastatic cancers, patients who got cardiac arrest, maybe except those who had witnessed cardiac arrest with immediate bystander CPR and a very short low flow time also were indication. But when looking back and what we did, there was almost no patients who did receive VV ECMO in that situation, or VA. MV duration has been associated with worse outcome in VV ECMO patients for decades now, and we define here a threshold of 10 days. When looking back, most of the patients got ECMO within the first, let's say, 5 days post-intubations. Some of them, especially young patients, those who did not have associated comorbidities or severe organ failure, did receive ECMO up to 15 days post-intubation, but it was not very frequent. And the last obvious also contraindication was multiple organ failure. Those patients with severe shock, high dose catecholamine, maybe except isolated AKI, which is more a feature of the disease than a real contraindication to go for ECMO. This is the data from the Paris area. These data are still under progress. These are the data from last week. There's been 279 patients who did receive ECMO. And of these, 76 patients died. 75 are actually right now weaned from the device, and 128 are still ongoing, which is 48%. These data need to be consolidated. It's early to provide accurate and trustable, reliable data on the outcome, and clearly we need more data. In the EOLIA trial, the mean time on ECMO was 2 weeks. Probably these patients, the COVID-19 patients, will get ECMO for a longer period of time, especially some patients we have right now, patients in the ICU on ECMO for more than 4 weeks. Clearly these patients may need up to, I don't know, maybe 6 weeks, 7 weeks of ECMO before they can be weaned from the device. It has also been mentioned before, but these patients are not the same. And this is a letter which just been accepted by Critical Care about the initial experience here in the department. Of the first 50 patients who have been hospitalized in my ICU, we got 8 severe PE, and including 4 patients who developed PE while on VV ECMO. And we had never observed that phenomenon before, and especially in the EOLIA trial. So this has major clinical implications. So first, we modified our strategy for anticoagulation in those patients. For VV ECMO, we used to treat patients with very low dose heparin and fraction heparin, and we have moved now for full dose heparin in these patients. And there's also a need for routine and careful monitoring of Doppler echocardiography monitoring to detect the early signs of acute cardiopulmonary in these patients. And also in those patients on ECMO worsening, if you have some worsening in hypoxemia or hypocapnia developing under mechanical ventilation, these also may be a sign, early sign of PE, which should be looked for, and those patients should get a CT very early in the course of the disease. So these are my very first conclusion, and once again, we need time to evaluate the results of this very difficult technology in severe COVID patients. So the first obvious observation is that it's possible to stabilize the patient on ECMO. It was said at the beginning that all patients die on ECMO. This is not true. We have weaned now a lot of patients, and some of them after a couple of days, up to 10 days of ECMO support. The others may require more days, maybe some weeks of support. But once again, we got very encouraging results here in La Pitié. Here in the Sorbonne University in La Pitié, we treated close to 80 patients, and the results are even better than the results I've showed you just before, probably because we have more experience in the care of these patients, and this could also probably be described some kind of experience and outcome associated with the volume outcome data and implicating different results also for these very severe patients. So this is my conclusion, and would be very happy to answer some questions.
Thank you so much, Alan, for that incredibly concise report of an extremely impressive and helpful experience. I have a couple of questions, and then we have time to open it up to the moderators who can take questions from the audience. Could you help us understand, in the 25% or so of patients who died on ECMO, what was the mode or cause of death, and what do you see as the main predictors of mortality on ECMO?
So most of these patients died early of multiple organ failure. This is something we know very well from H1N1 patients, so all the type of severe respiratory failure patients who put on ECMO. And definitely age and organ failure at the time of ECMO initiation are very important factors for the decision, maybe even more important than for conventional other type of indication of ECMO for respiratory failure. And here, patients, let's say over the age of 60, 65, who already have developed severe shock, the decisions probably might not be reasonable. To go to ECMO might not be reasonable.
And what have you seen in terms of neurological recovery in your patient cohort?
So this was also a concern for us because of the increase of in the anticoagulation level. So far, the patients who have been weaned from ECMO are doing quite well. These are very sick patients. These are patients who spent 2 to 3 weeks on mechanical ventilation and EV sedation. So most of these patients may have some confusion or other types of delirium following removal of the device, and you need to be very patient with these patients. And once again, this should be reevaluated maybe days or even weeks after the patients have been weaned from mechanical ventilation, has been sent to a rehab center.
A lot of questions from the audience specifically focusing on your anticoagulation protocol. So what target APTT or ACT are you using? What drugs are you using?
So we're using unfractionated heparin, and the target APTT is around 2 times the control. So it's between 70 and 80 seconds.
And how are you handling tracheostomy in these patients that are essentially being ventilated for weeks, if not months?
So our policy is not to tracheostomize the patients very early because now we have been proning also these very sick patients on ECMO almost every day, especially during the first week or so. So once the patient has been tracheostomized, it's less easy to put them prone. The second reason is that you may benefit from a tracheostomy if it's possible to stop sedation. But most of these patients, once you try to stop the sedation, they get crazy with a very intense and heavy respiratory drive, agitation, and it's at least for the first week or 10 days, very difficult to stop sedation. And if you cannot stop sedation, there is no benefit of the early track. We did track some of these patients, but it was mostly for those who were still on the mechanical ventilator after 2 weeks, and for whom the anticipation for weaning from mechanical ventilation was at least 10 more days at the time we decided to go for the track.
What advice do you have for cardiac surgery programs that have either very limited or no experience with ECMO and are considering instituting ECMO programs in response to COVID?
So there's different questions here. I think now ECMO should be part of the treatment available in any cardiac centers because of the need for mostly VA in the case of cardiogenic shock. VV support is very different. It's not about cannulation. It's about the care of patient for days or even weeks until the lungs can recover. So my advice would be to coordinate within a network. It was very important here in the Greater Paris to be able to take care of patients in the big cardiac surgery centers from the private hospitals, because at the beginning of April, when we got the tsunami, this would have never been possible to pass through this tsunami without the help of all the public and private hospitals in the Greater Paris. So this was possible also because we did have a strong network and coordination. We had a WhatsApp also discussion ongoing almost all of the day with questions coming from centers. I got many calls also from centers with less experience to discuss severe patients, to discuss the management of these patients. So it was clearly here a common effort from dozens of centers in the Greater Paris.
And can you clarify what proportion of your patients are on VV versus VA and what your indications are for using VA over VV?
I would say that up to 97, maybe 98% of the patients did receive VV. We did treat 1 or 2 patients for what was looking like a severe myocarditis, but it was very few. And the other indication for VA was severe pulmonary embolism. And once again, we treated maybe 4 or 5 patients who did have severe PE, including patients on VV, in whom VV was switched to VAV by adding an outer cannula to drain the right side.
I think Alex had a question about TEG.
TEG.
The question was if you use ROTEM or TEG to guide your anticoagulation management. I think a lot of the panelists had questions if you use, what was specifically used to guide your anticoagulation.
So now we stick with the very simple and basic APTT. We are testing many other possibilities like the TEG, ROTEG, or other types of new modalities, but it remains for now the matter of research. And for the care of the patient at the bedside, it's APTT. There's a lot of data showing that the ACT is not accurate for moderate doses of heparin. So this is the way we do it. This is not entirely probably we should get in the future better options for monitoring. But this is probably up to now, the APTT is probably one of the most easy to get and the most reliable, especially in our unit. Here we also have the anti-10A, but probably the reagent which is used by the lab here is a bit different from the reagent they have in other labs. And for us, usually when the APTT, when the anti-10A goes over the threshold, the APTT is already at 2.53 times the control. So we still stick with all the limitation we know about the APTT, we still stick with the APTT.
Couple of technical questions. How are you cannulating for VV ECMO?
So we used a very simple femoral cannulation, eco-guided. Usually it's a 25 to 29 French for drainage, positioning the tip of the cannula within the right atrium to get full drainage. And it's very important here to get full drainage. Otherwise, you may get severe hemolysis if you try to push the blood flow over 5 liters per minute, which is needed in these very severe patients. And the return cannula is 19 to 21 French, a short one, which is inserted through the jugular vein into the SVC.
And then finally, and thank you for providing such granular information. In your experience, how long have patients remained on the ventilator after successful decannulation from ECMO?
We do not have the final data about that. Some patients remain a couple of days, and others may need 2 to 3 weeks to be weaned from the mechanical ventilator. We need data, and this is very important for the future and the future of the treatment of these patients to have these data, but we do not have the full picture right now.
It's absolutely superb opportunity to hear from you. We're going to make sure that the manuscripts that you presented that show your algorithms, your experience and your protocols are available on both the SCA and the CTSNet websites. Thank you so very much for your time and expertise. We're now going to shift gears slightly and talk about transplant, solid organ transplant in the era of COVID. It's my great pleasure to introduce Dr. Amy Fiedler, who's an assistant professor and the Associate Director of Heart Transplantation at the University of Wisconsin. Thank you very much for joining us, Dr. Fiedler.
Thank you for having me. Let me share my screen here. So again, thank you for having me. I'm Amy Fiedler. I'm an assistant professor of cardiac surgery at the University of Wisconsin in Madison, and it's my pleasure to discuss heart transplant during COVID-19, risk, strategy, and early outcomes. I have nothing to disclose. So an outline of this presentation is going to be review the ethical considerations surrounding heart transplantation, discuss the magnitude of risk as well as the mitigation of risk in the era of heart transplant and COVID-19, talk about institutional strategies for continued productivity with respect to your cardiac transplant program, touch upon some very early outcomes at my home institution, and I'd welcome any questions. So ethical considerations of solid organ transplant really are the foundation and the underpinnings of everything that we do. And I'd like everyone to continue to think about these 6 ethical considerations as we move forward in this presentation. The first is do no harm. The second is do good. Third is autonomy and respect for the individual, utility, justice, and efficiency. And if we keep these ethical considerations in mind, it will guide us and it'll allow us to adapt to the changing landscape of the COVID-19 pandemic. We all know, and we've heard from our prior speakers, that COVID-19 has really hit us all quite hard. This graph was taken from the UNOS website, and it represents the number of adult heart transplants per week in the United States. We can see a very sharp downturn at the beginning of March and trending out towards April 12th. So you see the week of April 12th, only 45 adult heart transplants were performed that week. And you can compare that to say February 2nd or February 9th, when there were about 75 adult heart transplants that were performed that week. So not only is the nation suffering from this massive pandemic, but our patients who are waiting desperately on the waiting list to obtain a heart transplant are suffering as well. So the question is, what is the risk to our patients and our stakeholders in our cardiac transplant programs in light of this pandemic? And how can we continue to potentially provide life-saving heart transplant in the era of COVID-19? So clearly the magnitude of risk is high. There's a lot of different people that are impacted by this pandemic from a transplant perspective. Most importantly are our patients, providers, the donor selection protocol, our procurement team, the OR team, and ultimately the family and the community to which our patients will go to after they discharge from the hospital from a successful heart transplant. Now we have all of these stakeholders that are at risk for us to, when we're performing heart transplant in the setting of a pandemic. How can we best mitigate this risk? Now we can mitigate this risk for our patients in a number of different ways. Many of us on this webinar have seen a drastic shift in our daily life with minimizing medical facility visits and shifting them to telehealth. That's certainly important in the transplant population as well. At our institution, we've been deferring routine surveillance biopsies. We're only doing them from a first biopsy after transplant and if the patient is symptomatic and most certainly would require immunosuppressive adjustments. Our patients need to continue to practice social distancing when they're outside of the hospital, and data has demonstrated that these patients should continue on their immunosuppression protocol. This should not be monitored changed in the setting of COVID-19. For providers, we need to continue with universal precautions, and access to testing is critical and key. Importantly, from a transplant perspective, is the procurement team. At busy transplant centers, we're asking our procurement teams to frequently travel long distances geographically to then interface with the different health system and then return back home. This clearly allows for a lot of contamination of COVID moving from one location to another. So we've seen a drastic shift in the world of heart transplant with the use of local recovery teams if possible. If we're unable to use a local recovery team, we need to minimize the personnel that go out on procurements, only the necessary people to retrieve that organ safely. And also at our center, we have a dedicated procurement team. So we have a team that goes out on the procurements, but does not interface with the recipient aspect of the operation in terms of minimizing the ability to pass COVID between donors and recipients. And finally, everyone on this call can understand that the OR team is of paramount importance, and all of the necessary precautions when we're manipulating the airway and operating on patients with respect to appropriate PPE, N95s during intubation, et cetera, and again, access to testing for all of our healthcare workers, our donors, and our recipients. Donor selection has changed as well in the era of COVID-19. For both donors and recipients, this starts with a screening questionnaire. And what we need to find out is if there have been symptoms of COVID-19 in either the donor or in the recipient. If the screening questionnaire is positive for a donor, we must decline that donor for the safety of everyone. If the recipient screens positive, we can defer that transplant, and that's why it's of paramount importance that we continue to stay in touch with all of our patients on the wait list to assess for symptoms and if they've been exposed. Now, if the screening questionnaire is negative and there's no confirmed exposure and a PCR test for both the donor and the recipient is negative, we can move forward with transplantation. And that's important because we need to be sure that the entire team is comfortable that we are transplanting a COVID negative donor into a COVID negative recipient. Now, once we've managed and mitigated the risks, we turn to our societies to provide us guidance as to what we should be doing in these difficult and challenging times. The ISHLT has issued a statement surrounding heart transplant in the setting of a pandemic. They say that we do not recommend a general cessation of all transplant, as it is not certain that weighing of benefit and equity merits cessation of heart transplant in a pandemic. However, temporary cessation in the setting of an overwhelmed healthcare system may be unavoidable. Now, this is incredibly important because we do have systems specifically within the United States that are entirely overwhelmed, and they've been hit hard and are unable to continue to provide cardiac transplant. But there's a whole host of other institutions that can be able to pivot and work within these confines to continue to provide cardiac transplant for our patients. The question is how we can do this most effectively. I think it's important to think about the institutional strategy of transplanting in a pandemic with keeping in mind not only the ethical foundations of transplant, but also the ultimate goal of providing care for everyone, with the ultimate goal being to maximize the number of lives saved. Now, that takes into consideration COVID patients as well as transplant patients. And so we need to think of this in an interconnected way. And we need to divide the impact of COVID-19 on healthcare systems into stages to help us understand where our individual institutions are within the COVID-19 pandemic and how best we can allocate resources for not only our COVID patients, but also our heart transplant patients. So if we think about these stages, the anticipation stage, the stage in which the healthcare system is expecting a surge of COVID patients, we run the risk of underutilizing our resources as we're waiting for a surge. Next would be the active phase, when the hospital systems see a sharp rise in the number of COVID-19 patients in the hospital. However, we're not quite overwhelmed yet. This also runs the risk of underutilizing resources while we wait and anticipate becoming overwhelmed, as well as increased COVID within the system, causing healthcare worker transmission and some workforce issues. Next is the overwhelmed phase. We're seeing this in New York and in New Orleans, where there's scarce resources. The infection risk is extremely high. There's psychological trauma to healthcare workers, and we have a workforce issue. The overwhelmed stage is very difficult to continue to manage and run a transplant program, but I would argue that with proper teamwork and planning, it is still possible to continue on even if the hospital is overwhelmed. Following the overwhelmed phase, we move into recovery. We might have inefficient resource utilization during this phase as we try to adjust to this new normal, and an infection risk still remains due to COVID-19 being present in the population. And ultimately, we land at the new normal, where we will all have lessons learned that will ultimately drive future care and practice, not only in the setting of a pandemic, but also as we have pivoted and adjusted our cardiac transplant programs. Now, this graph has been provided by the ISHLT, and it more or less demonstrates how different institutions can function with respect to their transplant program as they move through these stages. I'd like you to look at the dotted line A. This is a transplant program that effectively had an exaggerated response and reduction of transplant allocated resources in the anticipation phase of the COVID pandemic. This type of program is unable to provide for their transplant patients because they're waiting for something to happen, which may or may not happen. It depends on where your institution lies. This doesn't allow for an effective use of transplant resources. If you look at curve B demonstrates a transplant program that has started to downtick in the anticipatory phase, but has completely ceased operations during the active and the overwhelmed phase. Now, this is okay, specifically if your hospital is entirely overwhelmed. However, when you project that line out towards the new normal, they're still unable to provide the same level of transplant-associated activity that one would expect of their normal capacity. Curve C is most interesting to me. Curve C demonstrates a transplant program that has decreased in terms of their transplant resources during the anticipation and the active phase. However, they've done a nice job in terms of the active and overwhelmed phase of balancing resources to COVID-19 patients and non-COVID-19 patients. And in doing so, they're able to achieve that ultimate goal of maximizing lives saved and then ultimately reaching a new normal where they're providing their patients life-saving transplant at their capacity limit prior to the pandemic. So curve C, if possible, is where cardiac transplant programs in certain institutional systems should strive to be. Now, it's not easy to get there because this is a clear adjustment from the way that we currently run our transplant programs. And so the question is how we do this. Now, projecting a University of Michigan quote from a faculty member at the University of Wisconsin is somewhat taboo, but I'm from Michigan, so I think it's safe to say I can use Bo Schembechler and say the team, the team, the team. So we work in multidisciplinary teams constantly, and that's one of the great things about heart transplant, but it's never been more important in terms of the team than when we're trying to function and provide for our transplant patients in the light of a pandemic. So turning to and focusing on the multidisciplinary team. What this means is we have to have consistent and clear communication. The communication needs to be focused on capacity. We have to have a nailed down understanding of what the capacity of our individual institution is to provide for not only COVID-19 patients, but also transplant patients. So we need to know how many ECMO circuits we have available, how many ECMO specialists are available to care for the patients. We need to know our ventilator capacity. We need to know our critical care bed availability, as well as the availability of nurses and other healthcare workers to care for our patients. As long as we know this on a daily basis, we can adjust and pivot our transplant program to meet the capacity and achieve the ultimate objective. Frequent patient telehealth is critical, not just for normal visits, but really to understand if our patients who are on the waiting list have had exposures, if our patients on the waiting list are symptomatic, and even more importantly, if our patients on the waiting list are very crippled with fear about potentially coming to the hospital and undergoing a heart transplant alone in the setting of strict visitor limitations. So being in close touch with our patients so we can either defer or adjust their place on the waiting list is important. And finally, the contingency plans for the pivot. At our institution, we did a great job about planning in the active and the anticipation in the active phase. We're lucky here at the University of Wisconsin that we have not become overwhelmed. And since we have not become overwhelmed, we've been able to ramp back up in terms of our transplant productivity much more quickly than if we did not have that contingency plan in place. So really the team is most important in understanding the capacity of your institution as you project through these different healthcare system stages. Now, to shift gears a bit and talk about our early results with respect to moving forward with heart transplant in the setting of a pandemic. So here we've performed 5 heart transplants since early March of 2020. Interestingly, all of these patients have been status 3 and 4. We haven't had any status 1 or 2 patients that we've transplanted. One of these patients was a combined heart kidney. All of the recipients and donors were tested with PCR. We utilized local procurement teams when they were available. We've had no deaths. And interestingly, we've had none of our prior heart transplant patients who are living in the community immunosuppressed admitted to our hospital with COVID-19. So in conclusion, the risks of continuing transplant are high. However, the benefits are great and patient safety truly does come first. Individual center-specific strategy based on your healthcare system stage will allow us to maximize lives saved. The ethical foundations of transplant remain, however, we must adapt for pandemic medicine. And focused, team-driven, multidisciplinary approach allows for institutional adaptability and our continued ability to transplant in a non-overwhelmed system. Thank you very much for having me, and I'd welcome any questions.
Thank you so much, Amy. That was an absolutely terrific overview, and it's particularly helpful because it really encapsulates, I think, our approach across cardiac surgery. We have 2 brief questions. Firstly, do you have any data other than anecdote on the outcomes of transplant patients who subsequently contract COVID?
So only anecdotal evidence. There's been a couple of case reports out of China that have demonstrated 2 prior heart transplant patients who have contracted COVID. Both of them landed on a ventilator, but both of them did make full recoveries.
And then the second question is, have you been able to cohort your transplant patients within a CSICU so that they're not in contact with staff or patients that have COVID?
That's absolutely what we've done. So we have a COVID-specific unit at our institution here. Every single patient that comes into our hospital is tested for COVID, and our cardiac surgical ICU is filled with non-COVID positive patients. So we minimize the risk of our patients coming anywhere near a patient who's been admitted to our institution with COVID.
Perfect. Thank you very much.
Our final panelist is one familiar to so many of us in the SCA. Dr. Sasha Shilkat is professor and vice chair of strategy and innovation in the Department of Anesthesiology at the University of Nebraska Medical Center. She's going to be speaking to us perhaps of the most important topic that impacts every single one of us, all of our family members, all of the coworkers that we see, everybody in the grocery store. Honestly, it's everybody in this pandemic. Speaking to resilience in the face of COVID-19. Thank you, Sasha.
Thank you. I'm going to share my screen here with you. Okay, let me just go.
It's okay. Now it just has to be resilience in the face of technological challenges.
Yes,
which we're all experiencing.
I believe Dr. Shilkat is also managing multiple Zoom meetings for her children simultaneous to this meeting. So she is mastering all of the technological challenges.
Yes, there are currently 4 children on Zoom in this household right now doing class. So I'm glad that the bandwidth is handling this. Thank you so much to all of the moderators for putting this together and for inviting me to speak to so many of you. And thank you for the previous speakers. I learned so much, and just hearing that you are all facing similar challenges and overcoming them is actually good for my own well-being this morning. So I'm going to go through we're going to take a different shift now, and we're going to talk about your own individual and personal well-being and how you're handling that right now. And my hope is that in the next 7 to 8 minutes, I can give you some affirmation, and I can also give you some practical tips. But the first thing I want to say is that what you're experiencing is real, and to validate yourself. So I have one disclosure. I'm the owner of Brave Enough. I want to talk to you today about preventing burnout, and how I want to really encourage you to think of burnout and stress as a spectrum. We're all on the spectrum. It's really impossible to be a surgeon or an anesthesiologist right now and not be facing some amount of stress and challenge in both our personal and professional lives. And then I want to give you a few tips as we end today. So I think this is a slide that's kind of comical and funny, but it brings all the point to all of us that for many of us right now, not just financially, but just not knowing the next phase or the next stage of what our daily work life is going to look like kind of brings up this feeling of hopelessness. And we know from a couple studies, there's actually one that's coming out in ANA and anesthesia and analgesia this month on mental and burnout factors. But this study that was done in China showed that basically the entire healthcare team has been affected by this pandemic, from the surgical techs to the nurses to the environmental service workers to the surgeons and the anesthesiologists. We're showing increased physical and mental fatigue, increased stress and sleep disturbance, an increase in burnout, anxiety, depression, and mental health exacerbations. And I think this is important to point out because you might be thinking, well, this is really obvious. Of course we are. But I think there's an intentional kind of thought that we have as cardiac surgeons and cardiac anesthesiologists. We're held in high regard for our everyday resilience. I mean, you might be thinking to yourself, gosh, I stay up for 24 hours and do back-to-back transplants, or I'm used to taking care of super sick patients on ECMO. What's wrong with me? Why am I feeling this kind of flutter of anxiety? Why am I having times where I may feel afraid? Why am I finding myself almost getting emotional or tearful? What's wrong with me? And I really want to call that out because I've talked to a lot of my colleagues in both surgery and anesthesia that are having these thoughts of basically it's a secondary harm. Like, I should be able to handle this. I handle really huge amounts of clinical stress and work stress all the time. So I want to make sure that you understand that what you're feeling is normal and what you're experiencing is real, and to give yourself a little grace right now. So what is happening? Basically, we're having information overload. We are opening our phones in the morning and there are multiple emails or texts or information that is coming to us because every day we have changes in our policies, in our pathway, in the way that we fund off things like this. And we feel this immense amount of responsibility to stay up to speed. And that's a good thing because that means that we're good clinicians and that we're responsible partners. Then we have this huge occupational hazard stress that we've never had before, where we're thinking, should I come home at the end of my 24 hours in the OR, or should I go somewhere else and perhaps shower and take off my clothes and all these things and then go home so that I don't expose my family members? So there's an enormous amount of stress on how we take care of those around us. And then obviously there's just complete information overload and complete long hours of work. But at the same time, you might be finding yourself in a position where you are working from home certain days of the week, and then you're trying to help people that are there stay focused on their school or whatever it is. So our personal lives are completely disrupted as well. So this is what I really want to explain to those surgeons and anesthesiologists that are here. Resilient physicians experience guilt. Just because you're experiencing a feeling of guilt because maybe you're not working as hard. I keep hearing this all the time. Like, people that are working in our ICUs in Nebraska are saying, well, I'm not in New York, so I shouldn't be complaining. Even though they are working really hard, they are working on COVID patients, they are maybe working in ways that they've never worked before. For example, several of our house staff are now working as hospitalists to help the hospitalist team for screening. And they keep saying, well, I shouldn't feel stressed. So they have guilt for feeling stressed. And I think this is something we often do as physicians. It's okay to experience grief. We are seeing people, young people, our own age or younger, who come in and are really sick. And we may think oftentimes, okay, well, we see this all the time with our congenital patients, or we see this where someone has a trauma that's young. But we're seeing this more and more, and you might be feeling guilt for maybe not being sick yourself. And then many of us, and there's been 2 studies to show this just for the last couple weeks, we're experiencing significant sleep disturbances. So our brain and our neurological pathways of our brain are not shutting off in the night. And this may be evidenced by extreme dreams that you're having or remembering your dreams. Another thing is we're always on our phones right now because we're constantly being updated. So the blue light that we're looking at is actually influencing our amount of melatonin and the way that we're sleeping. And then we have varying degrees of stress. And I say this because this is really important. Stress and burnout, and it's all on a spectrum, is very individualized. So Alex Mitnock and I could work in the same ORs, and we could work with the same people and the same patients, and the way that he perceives stress and processes his stress is going to be very different than my own. So I want to give you this tip. I want you to check your pulse every morning. And when I say that, I want you to check your own wellness vitals. And the reason this is so important is because all of us, especially those of us that work in cardiac surgery, we are very, I think, select amongst surgeons and anesthesiologists, and that we have to communicate with one another. We stand sometimes not 6 feet apart. There's just a drape in between us. And many times at our surgeons and as anesthesiologists, we spend more time with one another than any other physicians do in our workplace. And we have to communicate. And we all know that one of us having a hard time or not being well that day or having immense stress because of something going on outside of our control affects our partner in the room. It affects our clinical colleague. So I would like us to reframe and think about that person as your wellness buddy for the day. I mean, can you imagine? I mean, this is kind of, shocking, but can you imagine if you walked into the operating room and you saw your surgeon, or if you're a surgeon, you saw the anesthesiologist as your wellness buddy? So let's do a mental check. What is your baseline? Many of us are waking up in the morning and we're literally thinking of something we thought about at 3 in the morning that we don't know the answer to regarding either PPE or a pathway or a protocol. That, to me, when I'm waking up at 5 a.m. and I'm thinking, oh, remember when I woke up at 2 in the morning and I needed to read about what we're doing on coagulation, that tells me I'm not getting good sleep and I'm stressed, and that I actually need to stop before I go into work or before I go around my family and give myself a little mental check, whether it's listening to something for 5 to 10 minutes or just bringing down, not really my pulse, but my brain. The second thing is asking yourself how you're sleeping. This is huge. Sleep right now, these studies that they're doing, our partners in sleep medicine are doing a lot of studies right now that are showing shocking results, that we are not sleeping. Even if we're in our beds, our brain is not resting. So this is a really important thing. Things that you can do: turn off the phone, turn off devices early, about an hour before bed, and kind of prep to go to bed, almost like you would prep to get up in the morning. Prepare yourself by making sure the blinds are dark, that you're maybe reading something. Reading is so much better, actually, a book or is so much better than reading than your phone. And then there's varying degrees of stress in one day, right? And the last thing is laughter is legal, okay? I really want to encourage you to laugh. I think that right now, humor is so good for us. It's actually really good for our mental state. And right now, I know in our ORs, when we hear somebody laughing, everybody kind of looks at that person like, what are you doing? This is a really serious time. But I want to actually encourage you to laugh and encourage you to think about that. So I want to end with some tips. Number one, do meaningful work for you. And this is really, really important, and how we care for one another. Because what you can do during this pandemic is different than what your partner can do and what is meaningful for them. So let's try to encourage one another and really avoid any shame. I mean, right now I'm seeing a lot of shame on social media, like in comparison for how hard we're working. Those are really negative pathways in our brain. And so what may be really meaningful for you, maybe it's to write an article, or maybe it's to help your community with masks, or maybe it's to bring food in for your colleagues in the ICU, or maybe it's to, read and really learn about a specific thing. That's what is important for you. And so let's respect the diversity of how we're getting through this pandemic and how different people are getting through this pandemic. And then the other thing is sleep hygiene. Okay, so how are you sleeping? How are you getting, I'm sorry, I screwed that up for a minute. How are you getting through this? And I talked about that. And then the third thing, get outside. Even if you're living in a place that's cold, get in front of the sun, sit in the sun for 15 minutes. There's a ton of evidence to say that this can really boost you. I'm sorry, we lost my screen. Hold on a second, let me share the screen again. That you can really be boosted by the ability to sit in the sun. Even for 15 minutes of getting that vitamin D does wonders for your brain. So especially if you're in the OR or you're in the ICU, find a window in your hospital, take that break sitting in the sunlight. The fourth thing is don't underestimate community. I can't express this enough. You don't need a million friends, but you need one buddy at work that you can check in with and say, you know, today I was stressed because I'm going home after I've had this exposure, or today it took forever for us. We just felt really inefficient. I think there's a lot of us that are feeling frustrated right now because we're so efficient normally in cardiac surgery, and we're having to do all these extra steps just to get a patient in the OR. So that's something you can share. The other thing is beware of numbing. And I don't want to shame anybody for watching Netflix and drinking a bottle of wine every night, if that's what you find yourself doing right now. But those are numbing behaviors. And if you're starting to feel yourself withdraw and all you want to do is just watch something that is meaningless, or not be around your kids, or not be around your partner, or not be around your family, or even withdraw from your colleagues, that's a red flag. So let's look out for one another. If you find yourself mentally needing to numb at the end of the day, that's a red flag to yourself and your own well-being, that you need to get outside, that you need to go for a walk, that you need to do small things to maintain your own health. And then the sixth thing is just control what you can. We can't control who comes into the emergency room. We can't control all of the financial impact right now. We can't control the stock market. We can't control the grades that our kids get in classes. And I just want to encourage you to give yourself a little cushion of grace right now. We all need grace, and we're not going to be firing on all cylinders every day. So just control the things that you can for your own well-being, and look out for that buddy in the operating room.
Thank you so much, Sasha. That was a really meaningful overview of the things we can do. And so many of us think that we're already doing a lot of things to help look after ourselves and each other. But I, for one, know that I'm going to take away points from that and go sit in the California sunshine today over a cup of coffee with a colleague to make sure that I'm connecting with people. Not to cure COVID, just make sure nobody on this panel is recommending sunshine is going to cure COVID. Please don't put your venous reservoirs out in the sun.
No, it's only good for your own wealth or health and well-being. Sit in the sun somewhere for just a few minutes.
Sasha, we've had lots of questions actually come in for you. Can you, briefly given time, can you speak to any advice you have for colleagues who have been redeployed in areas outside of their scope of practice?
Yes, this is a huge amount of stress, and it's really challenging because we feel that we should know everything, and we're so used to being subspecialized. So I want to first say thank you, because that's a huge thing for you being redeployed. I know this week I'm going to the ICU for 2 days to shadow, and to learn how to chart in the ICU, and I'm already feeling anxiety about that. So number one, feeling anxiety for whatever you're doing, even if it's going to screen patients in a new area or taking care of a different type of surgical patient, that is very, very normal. I know this week I was really stressed about having to teach my children, and they weren't doing as well as I wanted. And I had to keep telling myself, I am not an elementary school teacher. This is not my training. So give yourself some grace and just realize that what you're doing is enough. Even if it's maybe not your A++ work, no one's expecting that right now. You may be expecting that because you have high regard for yourself, but you know what? You being deployed and doing C work somewhere is still better than not going at all. So thank you, and give yourself some grace.
That's great advice. Thank you, Sasha. Your final question is, what steps are you taking, or what do you recommend in terms of managing the risk of bringing COVID home to family members and children?
Yeah, this is something that I think most of us are really struggling with. And I personally, I have been pretty much, I look like a homeless person when I go to the hospital every day because I'm not wearing makeup, I'm not wearing jewelry, I'm not wearing anything that I feel like could potentially be a fomite. I'm wearing like casual clothes that I plan on burning when this is all over, but I don't know that it's going to be over. So I pretty much come home, take off all what I'm wearing, change into something in the garage, put all my stuff in a bag. And this may be extreme, but then I just go and wash it. I'm not taking any shoes or anything into my house and going straight to the shower and showering and then being around my family. I don't think that I think that you have to do what you feel makes you feel the best. I mean, I've even gotten criticized by some of my colleagues for doing that. Like that's overkill. That's, hysterical. But if it makes me feel better and it makes me feel like I can hug my son when I come home, then it's worth it for me.
Thank you.
Those are absolutely terrific insights. Since we still have 1,000 physicians on the line, I have a couple of questions, one for Dr. Fiedler and one for Dr. Coombs. So Dr. Fiedler, can you comment on the impact of false negative testing in your assessment and workup of transplant recipients and donors?
So I think that's a really excellent question. It's hard to know, if it's a false negative. What we've been doing here is that if there's any question, meaning if the patient develops respiratory symptoms or any symptoms that are concerning for COVID, we will retest. But it's a difficult situation if you're testing a donor and a recipient and it comes back a false negative, you move forward with the transplant. But I think the best thing that you can do then is in the recipient, if any signs or symptoms are shown, just continue to retest.
I think that's absolutely true. And I think transplant is a microcosm of cardiac surgery generally. We are testing all patients, we're screening them within 48 hours, elective urgents as we can. And I think it is incumbent on us to have a very clear and informed conversation with the patient, that they understand the risks, that there may be a false negative, they may have a compromised postoperative outcome. And even if they are negative, they may catch COVID once they're discharged from hospital. And I think it speaks to the importance of reevaluating our discharge plans. We cannot be discharging our frail patients to healthcare facilities that have a high prevalence of COVID and extremely poor outcomes. One question for Dr. Coombs, which is clearly related to UNIT's experience. In your vast experience of ECMO, can you tell us what different considerations we should think about for patients that are pregnant on ECMO?
We had actually 2 patients who were pregnant, and the outcome was quite good for these 2 patients. We have a close collaboration here with the gynecologists when the patient arrives, and it depends on the term. If it's below, let's say 20-24 weeks, we care of the mother, not of the baby, and it's only after, let's say, 24, maybe 25 weeks of pregnancy that there is clearly a concern about the outcome of the baby. And once again, the very few ladies here pregnant who needed ECMO.
And what are you doing differently after about 26, 28 weeks?
The problem is about anticoagulation and the risks of hemorrhage, of severe hemorrhage on ECMO. So once again, the situation did not come up here. We did care previously H1N1 patients with ECMO, when once again, it really depends. The complex situation is between 25 and 30 weeks because at that point, the baby might be viable, and this is the major issue, and the balance between the care of the mother, which may require full anticoagulation, and all the risks associated with the coagulopathy and the low platelet count, which is sometimes seen in these ECMO patients, and the risk associated with the babies. This is the complex issue.
Thank you very much. I'd like to thank the CTSNet and the Society of Cardiovascular Anesthesiologists for hosting this absolutely phenomenal webinar. I'd like to thank our co-organisers, Dr. Matthew Patterell from the University Hospitals of Coventry and Warwickshire, and Dr. Alex Mitnach from Westchester Medical Centre. My co-moderator, Jessica Brock from Stanford University, who actually did the bulk of the organising of many of our speakers. I would also like to thank very sincerely the administrative team from both CTSNet and the SCA, which includes Emily Robinson, Colleen Laura, Catherine Joyce, Janet McNeil, Sarah Dittmar, Jeff Rush. And I would like to emphasize that we're providing answers to as many of these questions that you've been asking as possible on the CTSNet COVID resources page. And you can access a recording of this webinar and other resources on the CTSNet and SCA web pages. The Society of Thoracic Surgeons, the STS, is hosting a joint webinar tomorrow at 2 p.m. devoted to restarting valve programs, and a global summit at 11 a.m. Eastern Time on May the 4th to reactivating cardiothoracic surgery programs. So I will hope you will join for those, which promise to be very informative. Thank you very, very much. Hopefully see you all online soon.